Hi, everybody. I'm Amy McMillan with Treat Dizziness at Home. And today I'm here with Dr. Alexa Fiffick, and she is the owner of Concierge Medicine of Westlake in Ohio. She is a primary care physician who specializes in women's health and an industry leader in the women's health area. So thank you so much for joining me today, taking the time to speak to me and my community at Treat Dizziness at Home. So today's topic is all about hormonal related dizziness. But first, I just want you to introduce yourself, your background, and a little bit about how you got interested in women's health.
Awesome. Thanks for having me, Amy. Like Amy said, I'm Dr. Alexa Fiffick. I am a board certified family physician, but I also have specialty fellowship training in menopause and other complex hormonal conditions. So I practice here in Westlake, Ohio. I'm born and bred Clevelander. Did all of my training all over the country, pretty much any state east of the Mississippi, was part of this journey. And I actually thought I wanted to be an OBGYN is the answer. Thought I wanted to be an OBGYN, did all of my rotations in medical school, and very last minute kind of came to an epiphany that despite what I was being told, it is possible to actually take care of women and make a difference outside of the traditional OBGYN kind of pathway. And so took a really hard left turn last minute at the end of medical school and went family medicine, knowing that women's health was always my passion, and did an extra kind of certificate of training during my residency in women's health, did extra elective rotations through all the different women's health opportunities at my hospital system at the time, and came back home to do fellowship at the Cleveland Clinic in a program called the Specialized Women's Health Program, which is basically focused on all the non-reproductive things about women's health. So osteoporosis, osteopenia, menopause, perimenopause, PMDD, PCOS. I could list a whole lot of boring things. But realistically, it's everything that kind of falls between the gaps in women's healthcare. And so that was really what was always intriguing to me, and was told that I probably needed to go more of an OBGYN route in order to specialize in those things, and ended up figuring a different way out. So here I am, opening my own business.
Great. And I'm glad we have you for women's health representation, because I cannot tell you, one, how many questions we have in this community saying, my symptoms are 10 times worse around my cycle or menopause, or how do I know I'm in perimenopause, which we will get to all of that. But it definitely feels like an underserved population. And then women are just left to say, it's just your age, just deal with it like everything else. So thank you
It's
for what you're doing.
normal. Yeah.
Yes.
Yeah.
So let's talk about hormone related health issues in women. Can you explain how hormonal fluctuations can trigger or cause dizziness in women?
Yeah.
And if
So
there's
I think
anything pertaining to men too, just let me know. But I just figured causing
it is,
dizziness in
yeah,
women.
it's not the same. I'm not trying to cut you guys out, but the average kind of patient that I don't know, actually, from the PT world, we should have had this discussion offline. The average patient that all research studies and textbooks have been about historically have been a 70 kilogram, aka like 154, 155 pound Caucasian man. And so
Hmm.
all clinicians go through medical school and residency trained on what would be normal in a man. And so their hormonal fluctuations, yes, they have some. It is not nearly the same. And if anyone wants to come at me about andropause versus menopause, you can bring me the studies and we can talk about it, because it's just not the same. So what happens to a lot of women, and what I like to kind of always correlate it back to, is all of these sorts of hormonal fluctuations causing instability somewhere in the body are really, really similar to each other. They present differently. For example, there's something called catamenial epilepsy, meaning that when I have my period or right before I have my period, I have a seizure. Same things with menstrual migraines, which obviously, vestibular dizziness, ophthalmologic, like all those sorts of dizziness, visual things can be triggered by that time frame as well, which is exactly how it feels when you go into perimenopause and menopause and those dips happen. So to be a little bit more specific, and interrupt me if I'm not like quite answering the question, Amy. But what happens is when you go through your menstrual cycles and you're following that along on a normal kind of textbook is 28, but normal is anywhere from like 21 to 45-day cycle. And you ovulate, right after that, your hormone levels, specifically estrogen, start really going down quite quickly. And on that decline is where we see a lot of symptomatology of that sort of instability. And then once people hit that sort of bottomed out level, like right when you go to start your period or right when you're at the bottom during perimenopause or menopause, that's when those symptoms really, really kick up a lot. And so one of the things that I kind of always try to bring it back to is, when are things happening? Because if I know when something's happening, I probably am figuring out the trigger.
Okay. Now, is there, and maybe this is too broad or too maybe it's actually too specific or scientific. How exactly do those hormonal fluctuations, what instability, is it on a neuronal level, affecting the nervous system? What exactly causes that dizziness besides the chemical instability? How does that work? Because a lot of people want to know the why.
Yeah. So it's a little bit of a tricky question, and I'll try to take it in little chunks. Number one, when we have dizziness, one of the things that I always need to rule out, and you always need to go see your doctor about at some point to make sure it's not this, are arrhythmias or heart rhythm abnormalities. One of the things that the blood vessels in the heart and other places, but specifically the heart in this case, what I'm talking about, respond to the lack of estrogen or the real big drop in estrogen is that the actual muscles and like the lining inside of your arteries gets kind of unstable and twitchy. And so you can have basically palpitations or cardiac rhythm changes, which when the blood flow isn't super consistent to your brain can make you dizzy or lightheaded.
Okay.
So what that one truly is just the lining of the arteries is unstable and becomes kind of overreactive with the loss of estrogen. Now, when we're talking about what's going on kind of in the brain, and a lot of people are capable of kind of correlating this more to if you think about like PMDD, premenstrual dysphoric disorder, clinical PMS, or that catamenial epilepsy, the shifts in the hormones play with kind of our narrow zone of stability. So if things are just not normal for that environment, it can trigger just a little bit of change that fluctuates, whatever that sort of threshold is. And so in terms of it itself causing dizziness, sometimes that itself is more along the lines of the way it plays into the brain. Sometimes it's the way it plays with the nerves from the ear that cause instability. And for a lot of people, it also has to do with POTS. So POTS in particular, we've seen become extremely prevalent after COVID and the COVID vaccinations as possible side effects of that inflammatory thing that happened with that. And so I see a decent amount of POTS patients who just become a little bit more unstable with those hormonal fluctuations as well.
Okay. And then I would assume some people with, if they have any dizziness related to fluid fluctuations, so maybe endolymphatic hydrops, Meniere's disease, I suppose those also with the fluid fluctuations may be affected by hormones as well.
Yeah, so we know that when you are more in a progesterone heavy portion of your cycle, that tends to be like a fluid retention time frame. Realistically, that matches up where you are with like in the middle of a cycle, versus the beginning is kind of when you're trending downward with your estrogen, your progesterone's kind of going up. It's the body's way of mimicking, like, hey, we're going to throw a bunch of progesterone at something in case there's a baby growing in there.
Okay.
Progesterone thickens the cervical mucus and holds stuff in,
Okay.
which is partially why you have a lot more discharge when you're pregnant. But the progesterone helps us retain water, and that fluctuation can be, like you said, a decent trigger. Especially, we know that there are estrogen receptors in literally every like organ system in the body, connective tissue, joints, hair, skin,
Okay.
nails, teeth,
Okay.
bone, like literally everywhere. And so part of that, I think, is the way that it has interplay within like the nerves and the bones potentially in the ear.
That actually makes a lot of sense, that if the receptors are everywhere and there's instability, then of course our physiology, our neurotransmitters, everything is at, I always say, our body is kind of like a cake. You have to have the right ingredients at the right level. And if you have a cup of salt instead of a cup of sugar, you still have a cake.
Right.
It's just not going to taste right. It's not going to
Yeah.
function right. It's not going to look right. So
It's
the
like when
right
you
ingredients.
forget to mix your sugar with your butter before you put the other stuff in.
Yeah. Yeah.
Yeah. And one of the things that I didn't say that I was thinking of like during that answer was estrogen and progesterone, specifically estrogen, more so decreases the seizure threshold in women. So if I have a patient who is an epileptic and I have her needing menopausal hormone therapy, whether or not she has a uterus, we need to typically give progesterone so that she has some floating in her blood to kind of match up with that estrogen. So that just those changes just a little bit, it makes a hyperreactive environment even more hyperreactive.
Okay. Oh, I have so many more questions just on that, but I have to keep myself in line and organized. So, so let's see if we can answer this. What are the most common hormonal stages or conditions where women experience dizziness? Do you think we already answered that?
A little
Hormonal
bit.
stages. Okay.
Yeah. So a lot of times it's right before the period and then right during the beginning, like the first day or so.
Okay.
If it's menstrual, perimenopause is a really common one too. What people don't realize is with that instability in the cardiovasculature, that arrhythmias and palpitations that are not able to be necessarily seen on other cardiac evaluations,
Hmm.
are a very, very prevalent perimenopause, menopause symptom. And it really kind of boils down to where women struggle with their cardiovascular kind of anatomy compared to men. Men, we always talk about heart disease being in those big vessels. Everyone's
Mhm.
heard the words like widowmaker about the
Mhm.
LAD vessel. Whereas we really see a lot more in the microvasculature of women. And so perimenopause and menopause are a really common time for palpitations and rhythm changes. Another really, really big one is with pregnancy, because you all of a sudden are carrying a significant amount more blood fluid in order to maintain that pregnancy. And it can make people really lose, blood pressure a little bit more because we're adding fluid to an environment, and, it kind of stretches those receptors out so that it basically just makes you a little bit more likely to be hypotensive or low blood pressure. And that can make people really dizzy.
Yeah. And then probably with breastfeeding postpartum as well. I mean, I can
Yeah.
attest to that.
Yeah.
I almost, yeah, blacked out. I had to put the baby down. Yes, it was, yeah, I
Yeah.
was tanking quickly,
Yeah.
so I can
Your
attest
fluid
to that.
shifts with that are so drastic. And the other thing that people don't realize is that, and there's actually a recent article that just came out about it within probably the last couple of days, actually, about genitourinary syndrome of lactation. Because it really has been known for a long time that estrogen deficiency really shows up in the genital urinary system when you're menopausal. But that same sort of state is what's happening when you're breastfeeding. So you're also quite estrogen deficient in that time frame, which is why for some period of time, if you're regularly breastfeeding, you aren't ovulating, and why we talk about that being like your form of birth control is breastfeeding. But those fluid shifts and that estrogen deficiency can make people just super dizzy.
Okay. So let's see. What are common symptoms of hormone-related dizziness that women should be aware of? I think we started to discuss on that, but palpitations, I hear that one.
Yeah, I hear palpitations a lot. Sometimes that's when I start keying into more of like the POTS picture of I get dizzy every time I stand up, or I used to be able to cycle and now I can't because I bend over to like unbuckle my shoe and I feel like I want to spin off the bike. Specifically, I think the things to keep an eye on are, do I feel like this is only when this kind of situation is occurring? Like, is it right before and during the beginning of my cycle? Or is it, hey, there's always something else going on? I always, do an entire workup on a patient with like palpitations or feeling like heart racing, skipping beats. But it's a good thing to kind of keep an eye on. It's every time I take a hot shower, it's every time I, change temperatures or change positions or stuff like that, that cue me to figure out, is it just the hormones fluctuating that the body can't handle, or is that worsening some underlying thing?
Okay. Now, would you say, people are diagnosed with vertigo. Vertigo, we know, just means, they feel like the room's spinning, dizzy, but we don't know the source. But if you had to say, if somebody would ask, if I feel actual spinning, and it's almost, or even like rocking, say it's consistent, say it's almost all the time, and it just is worse when I walk around. That wouldn't be hormone related, would it? Yeah. Okay. So you're looking for
No,
these.
you
You're
got to
looking.
come see me. We'll talk about it, or see your doctor, and then I'll send you back to Amy.
Yeah. So what you're really looking for might be more these fluctuation type of spells. And
Mhm.
then you start to find, okay. So yeah, you're
Yeah,
just seeing these, I don't know what's going on, but I feel good. And then
yeah,
then I hit a bottom. Okay.
yeah.
So that
It
might be
also,
a key.
yeah, it really helps. I know that it is super difficult for busy people. And I am not going to lie and say that I'm perfect at this either. But if you can, write down notes in like the note app on your phone,
Yeah.
even just like dates and of like, when's my period? When did I feel like this? It helps me figure out, because the biggest thing about hormonal symptoms is not that hormones are doing anything wrong. It's that something else about the body doesn't like fluctuation.
Okay.
And so, what I always want to make sure that patients understand is, even if it's like PMDD or something like that, if you feel like it's my hormones, that may be a trigger, but they're not functioning always in an incorrect way. And just because it's normal doesn't mean that it's something that you have to tolerate, or suffer through. And there's things we can do to help all of those situations that we listed already.
I'm excited to get into that. Are there any other common conditions that you want to speak to that are caused by hormonal dysfunction? You mentioned POTS.
Mhm.
Yes, we're going to do our cardiac workup if you think that something is going on there. Any other conditions specifically that people might say, "Ooh, I need a hormone specialist for these conditions"?
Yeah, so one of the ones that comes up a lot in my office is people having changes in migraine or headache type.
Okay.
And those are really common things to happen in perimenopause and menopause, specifically new onset migraine, or a change in the type of migraines or headaches that you've been having. A lot of times correlates to where you are in that trajectory towards becoming fully menopausal. And so it's really important to talk to your doctor, have them, do all the bits and bobs of the workup. Any change in headache, as any migrainer like myself knows, is if I'm having vision changes all of a sudden after going years without having that, that's weird. I should talk to somebody. And not to just chalk it up to purely the hormones. It's my job to rule out everything else. And then when I figure out that that is the cause, to treat that. But changes in migraine type, headache type, new onset, other things that may be key, weirdly, tinnitus. Tinnitus is a new onset issue in perimenopause, menopause for a lot of women, as well as the obvious things like the hot flashes, night sweats, brain fog, blah, blah, blah. So,
okay. And maybe somebody is interested in this, but I've had quite a few patients when they're young, they have your classic, headache type of migraine. It goes away for a while. And then all of a sudden, and I want to ask you about ages too, all of a sudden it's vertigo, spells, once a season. And it's really hard almost to identify. Some of my patients are maybe 50 when their first spell, and then every year, and now they're, 65. And I'm like, are we still having migraines? So can you speak to that at all? What, like the age range, and that people almost don't realize that your migraine type can change from your normal headache to all this different type of migraine.
Hormones are a weird thing. And I think they're awesome, and clearly like have dedicated a really large portion of my life to that. But one of the things that we see is just like, I always like to bring it back to something that I think people are familiar with talking about, changes in hair type or, texture after pregnancy, like, oh, I used to have straight hair and now it's kind of wavy, or vice versa. Those sorts of changes with big hormonal triggers like pregnancy, postpartum, perimenopause, menopause, can really cause major shifts. And so it's not unheard of in my office. It's obviously a lot more common, that specifically the transition from perimenopause to menopause, where you are fluctuating rapidly in the beginning of perimenopause. It's very erratic. Some days I could check your estrogen and you look like you're pregnant. Some days I check it, a week later and you look menopausal. They're really all over the place. And so that tends to be an increase or a worsening in underlying headache or migraine type. But it can also bring on new presentations. And then typically we see a decrease in frequency and severity once you become fully menopausal. However, I've also seen that shift from, it was classic with, nausea, vision changes, and the actual like throbbing pain, to pain's not so bad, but I'm also getting dizzy, or I'm getting like a new aura or something like that. Again, estrogen receptors in literally every surface of the body. So.
And let's quickly touch on just age. So perimenopause, is there an average? You can give me outliers, but what's the average for perimenopause? And then after menopause?
Yeah. So I like working backward from there, if that's okay.
Sure.
Menopause on average in the United States and Canada is about 51.5 to 52.5 years old. Normal menopause can occur anywhere between 45 and 55. And on average, perimenopause can be anywhere from 7 to 10 years. So if you're kind of doing math backwards from that, starting to have symptoms of perimenopause at 35 or so is not unheard of. Now, if you've gone, more than a year without a period, and someone like myself or another doctor didn't put it in IUD, take your uterus out, put you on some sort of other medicine that does that, it's worthwhile to consider whether or not you're in menopause. And when I get really stressed out about that for patients is when they're 40 or under. Kind of that early 40 to 45 timeframe is what we call early menopause. 40 to 45 is early menopause. And prior to that is what we have this terrible sounding acronym for called POI, premature ovarian insufficiency. Used to be called premature ovarian failure. Turns out at least 25% of the women that carry that diagnosis ovulate at least one more time. And so it turns out they're just kind of like on the fritz and may come back to life at some point for a minute or more. We don't really know. And what I don't really agree with is when younger women get told like, no, there's definitely nothing wrong with like the hormones or your cycles. You're not in perimenopause, you're having normal periods. Like none of that's true.
Okay, I was just going to ask, if you're having consistent normal periods, are we still possibly in these hormone fluctuations?
Yeah, absolutely. You can fluctuate rapidly enough that, especially in the beginning of perimenopause, you'll see slight tightening of the windows between periods. And then sometimes people will tell me like, oh, I just bled so close together. It was almost like I was bleeding for 2 straight weeks. And then 2 weeks later, I was bleeding for 2 straight weeks. So the fluctuations are happening. Even when you are actually right at the end of perimenopause, before you've become fully menopausal, you technically still have the capacity to ovulate because those fluctuations are still happening. The pattern is different. The pattern may not be a pattern at all, for lack of a better word to call it. But even if you are having normal monthly cycles, you can be going higher and lower than you used to, and that can feel really erratic from a symptom perspective.
Okay. Now, I think here's the most important thing. What can you do about it? So you as a physician, say we're suspecting, take me into the office. I'm a patient who has dizziness and I think hormones are related. What can you help with? How do you treat that?
Yeah, so depending on what the patient wants, I like to offer my patients a menu of options. So I'll always kind of walk you through the entirety of all the things that I have at my disposal to help you. Obviously, physical therapy is definitely on there in my sort of like lifestyle versus exercise nutrition kind of realm.
Okay.
But once I've done the physical exam, any imaging that I may or may not need to do, gotten some labs. And if I truly think like, you know what, this really boils down to the fact that it's straight up just her hormones. One of the things that is extremely helpful to do, either if you are premenopausal or perimenopausal, meaning getting ready to become menopausal, is to stabilize the hormones. And so typically in that stage, one of the best things for that is to use a type of birth control that suppresses ovulation. And so I frequently use that. I very much am a hormone nerd, so I like to tailor it to the specific desires and like needs for each patient, and choose a progestin or an estrogen or both that are the right fit for the right person. If that is not ideal for a patient, and say that there was some sort of other thing going on like cardiac or epilepsy or something like that, figuring out ways to stabilize that environment with other medications and to limit the effect of the hormones on that environment by kind of sort of stabilizing that environment for them. Additionally, it's really important for us to keep an eye on fluids at different points throughout the hormone cycling, especially when you are starting to bleed. If you are a POTS person specifically, or someone else who can't tolerate because you have really labile blood pressure, and you start bleeding quite heavily, that becomes a really big problem very quickly. So keeping fluids up, keeping salt up, that kind of stuff.
Okay. Now, how often are you, because I don't know how different your practice may be from maybe just a general OB who says, oh, why don't we try this birth control? How often do you think that we should be having our blood checked to see if our hormones are actually stable with this, medication option? How often are you checking your clients?
Yeah, so my patients, typically I add hormones in as part of that, like first, I'm trying to figure out what's going on, because I'm not only checking, your normal hormones like FSH, progesterone, estrogen, I'm going looking for other weird like endocrine stuff. So a lot of times I'm looking at things like prolactin, testosterone, DHEA, DHEAS, and some other things that are kind of in that realm, as part of my first workup pretty much all the time. Depending on if you are menopausal versus pre or peri, it sort of depends on like what each different situation is. But I would say that traditionally, it's at least once in the beginning and later on, probably again, depending on whether or not we're getting the outcomes that we're expecting from treatment.
Okay. After about how long? 3 months, 4 months, 6 months?
Yeah, usually probably in the 12-week to maybe 18-week mark.
Okay, so I think a lot of people would want to know that. Like, how long do I have to be on this birth control to see a stabilization of hormones? How long do I have
Mhm.
to let it work? So I think that's a good
Yeah,
point.
I
Okay.
think it's if patients or people listening have any experience with things like cholesterol medicine or antidepressants or anti-anxiety meds, it takes a little while to see effects. And so one of the problems with how we have traditionally dosed birth control and how we traditionally have started birth control is even when I was a family medicine resident and when I was a medical student, a lot of times the answers back to me when I'm like, I'm not really sure what I should pick. My attendings would say things like, well, just like pick one and then like see what happens.
Ah,
And a lot of women are and girls are really, really used to that. Which I think is part of why it's like so interesting to me. I like I said, with the menu kind of option, I usually come up with a reason that I want one thing versus another. I walk
okay.
you through those different options. For example, one of the ones that I do commonly for PMS and premenstrual disorder is drospirenone is the progestin. It's a synthetic progesterone. And the cool thing about that versus other progestins is that it also blocks our androgen or our male hormone receptors, which I always correlate to. We all know that guy in high school or college that was juicing testosterone and was like really depressed and angry, but he
Okay.
was getting like real swole. That is kind of what we're trying to avoid, is binding to those receptors to get those outcomes. So I try very specifically to pick based off of like their different receptor actions, and or if I know it has a side effect, use that side effect to my advantage. And so a lot of girls have always just gotten, oh, I was just like given some random pill and my insurance covered it. I try really hard to not ever have to do that, because there are some things that are going to be better for suppressing your ovulation. There are going to be some things that are better for mood, some things that cause bloating, others that don't. And knowing what your history with that has been, pregnancy, postpartum, all those things, like I want to know all of that to know what to pick for you.
Okay. And that sounds very, as you said, tailored. And I don't think that's happening in the normal medical community, right? Okay. So when
No.
somebody is looking for a hormone specialist, are there anything specifically that they should be looking for in
Yeah.
history and
So
education?
yeah, if you are, so I'm one of very few. I think there's probably just about 30 of us
Okay.
that have trained at the Cleveland Clinic Fellowship and graduated. There were a couple other fellowships that focused on that have since kind of disbanded, for funding reasons mostly. But the kind of commentary on someone's profile of like fellowship trained in or
Okay.
specialty trained in is really helpful. People that I think have even more training in the matter above kind of the norm. If you see someone and they work for a department, run a department, or have this on their credentials saying complex contraception, usually that's someone who, if you're an epilepsy girl, if you're a many years girl, or whatever your situation is, those people are going to be much more likely to understand the ins and outs. But for those who are not able to find that near them, usually you're doing pretty good if you find someone who is menopause trained. Again, the fellowship thing is not, the most common, but there is a website, menopause.org, that if you go to, you can find a clinician near you based on zip code. So you can type in your zip code and find a credential clinician near you.
Menopause.org. I'll put that in
Yeah,
the description of the
yeah,
video. That'll be a
it's
great resource.
it's quite helpful. I know, so like here in Greater Cleveland, there are a couple clinics that run complex contraception clinics.
Okay.
And sometimes it's what you think of when you're thinking like, oh, it's somebody who is like got really bad fibroids and needs an IUD, or it's someone who has, an old Nexplanon in her arm that needs to get out. But a lot of the times it's the girl has POTS, epilepsy, a cardiovascular disease, is a cancer survivor, stuff like that. And they're still a little too young to give up kind of the potential of having any children anymore, and what those options are for those people.
Okay. Now, I have a controversial question. There's a lot of social media medicine. I see a lot of people advertising that they are hormone specialists. Can you possibly give any things to look out for that maybe I don't want to say not qualified, but what's the difference between you and people with great social media marketing that claim they are hormone specialists? What are we watching out for out there?
Yeah, so I'm sure you, as well as everyone else out there, has gotten advertisements for people who are selling either classes or some
Yep.
sort of supplement or like coaching situation. Those are kind of some of my three things that really stick out. If you're profiting off of supplementation, I have an issue with that because it's a very unregulated thing. I know everyone wants to do things the natural way or the safest way.
Okay.
And in the hormone world, I mean, the fight that I have is an uphill battle every day against people that are talking about bioidenticals or
Yes.
synthetic blah 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 pellets. I could go on for days about these topics.
Maybe
Um,
we should do another one on that because
I
it's over
I
my
could
head.
totally, yeah. Anybody who is telling you that their way is safer, more natural, and in a lot of cases, it's a lot of cash pay things.
Yeah.
Part of the reason behind that, that's one of the only things I stand behind medical insurance on, is we have recommendations against it. And so they are not paid for by insurance companies because there is no guideline that has ever existed to recommend these things. And so supplements, like selling things in general, is just a very weird vibe to me. And if someone is not specifically a medical physician, I would be really, really wary. I know there's probably a lot of people out there who used to be a nurse that love to help people and kind of transition. That's not exactly who I'm talking about. I'm talking
Okay.
about like your random person who might have used to work in finance or sales or something, and are like, oh, because of my journey, I want to do this to help people. I just don't think they have the knowledge, and not always necessarily their fault, right? Like they find the information that they try to help people, but it's not valid.
Okay. Yeah. Thank you. I see a lot of that, like TikTok medicine and, you know, a million
Yeah.
followers or a million views. I'm like, wow, they must know what they're talking about. And it's just really unregulated and scary out there.
It is.
As
And
to
that's the
what people,
problem, is like you can go on social media, and because like other people, like, right, things I do and say are regulated by the medical board.
yeah.
So if I do something that's really sketchy, someone will find out and like do something about that,
Yeah.
versus these people on the internet that are selling different things, and like supplements is one of them. Like you don't actually have to prove anything to sell a supplement. You can say whatever you want on the label, because it's not regulated by the government. So anything that falls outside of those sort of regulatory mechanisms really opens you up to be getting all sorts of crazy claims that
Yeah.
do not have to be backed up. And I do not care what that person's, you know, Google reviews or Yahoo or whatever it is. Like, I don't care what sort of testimonials they have. If they don't have the right training and credentials and monitoring, like, it's questionable.
Okay. Yeah. So, with that being said, now do you just practice in Ohio? Do you do anything virtually, outside of Ohio?
Yeah, so not yet. If you did not know, there is something called a compact license
Mhm.
application where a really large portion of the states here in the US allow it to be a slightly easier process to get licensure in multiple different states. I am in beginning stages of that, ironically. So my
Okay.
goal is to I have a state license in Ohio. If you come see me in the state of Ohio once, the way that our laws work is that I can then provide telehealth to you anywhere in the country
Okay.
after that first visit. But pretty soon here, we're looking at hopefully quite a few more states.
Great. Well, look forward to hearing about that. I will make sure that I link your information, but very quickly, again, just give us your name, where people can find you, website or email, really quick, and then we'll wrap it up.
Yeah. If you missed it in the beginning, hello again. I'm Dr. Alexa Fiffick. I am the CEO and founder of Concierge Medicine of Westlake here in Westlake, Ohio. We offer concierge primary care and concierge specialty women's health, as well as consults. And you can find me at Dr. Fiffick at msmedicine.com or conciergemedicineofwestlake.com.
All right, thank you. So everybody, if you do, yeah, thank you. If you have any questions, drop them in the comments below. And until I see you next week, stay healthy, stay steady, and stay strong. Thanks, Dr. Fiffick.
Thank you.
All right. Pause.